On this episode of the ASC Podcast with John Goehle, recorded live at the 2024 Illinois Ambulatory Surgery Center Association's annual conference in Chicago, Illinois, we interview some of the speakers and discuss the benefits of membership in the association.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsor, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 228 of the ASC Podcast with John Goehle for August 22nd, 2024, recording from the 2024 Illinois Ambulatory Surgery Center Association's annual conference in Chicago, Illinois, and from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and Operations Manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by the relevant regulatory bodies. And joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
So, Sue, I had a great time in Chicago with the Illinois State Association meeting. It's the second time I've done that in a row. Last year was much smaller, I felt. This year they had a record attendance post-COVID, so they were very pleased with the attendance. I did a 4-hour session, an administrator's workshop session on the second day, which I hope some other state associations might do also. It was a great idea that Ross had. Ross Weber, who is the executive director there. And it was a great opportunity to discuss the role of the administrator and had lots of good discussions and dialogue with the attendees there. And I know this might be shocking to you, but 4 hours was not enough time for me to talk about all these things. But I really enjoyed the fact that there was quite a bit of dialogue. You know, I talk about this a lot with the virtual conference, how important it is to get people talking back and forth and asking questions. And that's the nice thing. The best thing about being in person is so much easier to facilitate those questions. I do want to thank everybody for the hospitality, and especially Ross Weber, as I mentioned, is the executive director who arranged everything. It was really a great experience. Now, I do need to point out that I used our portable microphone, which is not always the easiest to hear, as Sue knows when she went through the editing. We weren't able to use a full studio there because of the accommodations. But again, it was a great opportunity. Hopefully, I'll be back there next year also. Now, what I did is I had an opportunity to interview 3 people, actually 4 people total, but 3 of them were speakers at the conference. And we're going to start with Ram Kamath. He is a pharmacist and a pharmacy consultant in the Illinois area, and he's with Canara Associates. And he spoke about drug diversion. So let's listen to that interview. I'm here at the Illinois State Association meeting in August of 2024, and I'm here with Ram Kamath, who is a pharmacy consultant here in the state of Illinois. And what other states are you in, Ram?
Wisconsin and Northwest Indiana.
Beautiful. And I just finished listening to you do a wonderful presentation on drug diversions, which of course is a huge issue right now. I know we talk about it on the podcast enough, but it does seem to me to be one of those topics we just can't talk about enough. Can you talk a little bit about what you discussed during the session.
Yes, I mean, healthcare personnel have easy access to highly addictive controlled substances.
Right.
And that somewhat is, it's very easy for them to divert.
Yeah.
And healthcare personnel seem to prefer prescription drugs diversion instead of buying same drugs or similar drugs from the street.
Right.
Because every day you read in the newspaper, so many people died of contaminated drugs that were spiked with fentanyl or something else that you don't even know what they are getting.
Right.
So healthcare professionals administer these drugs every day to their patients safely, so they feel much comfortable diverting prescription drugs, and they have easy access to it. You know, like anesthesiologists of all the specialties, medical specialties, anesthesiologists are known to have highest rate of addiction because, again, easy access. Mm-hmm. And that probably is the reason.
Well, you also made a comment that there's warning signs of somebody that could potentially be diverting. What were some of those warning signs that you should watch out for?
Warning signs are rapid mood changes
in
the person. That is number one. I have seen it happen when I worked in a hospital pharmacy. One of our pharmacists was addicted. At that time, this was in mid-80s. Cocaine was a big drug at that time. He will go to the bathroom and come back a totally different person.
Yeah.
He'll be happy 1 minute. After some time, he'll be the nastiest person to you.
Right.
Oh, mood swings, heavy mood swings.
You also mentioned just long bathroom breaks in itself.
Yes, long bathroom breaks, frequent breaks, and unsteady gait.
Yeah.
And for long-term addicts, tremors, hand tremors.
Right.
I know if they have Parkinson's disease, it can happen, but these are young guys, and they did not have Parkinson. And when you see them hand shaking, you wonder what is happening here.
Right.
And those are some of the symptoms of individuals. And the other trait of these individuals, they are extremely smart, and they are very nice to coworkers.
And there are people that you would often least expect.
Yes.
Right.
Least expect, and you trust them.
Right.
In fact, I can give you an example which I have not discussed at the meeting. One of the surgery centers, the administrator was extremely strict. I mean, his level of strictness was beyond imagination. Even the log sheets they use were serially numbered. And everything has to have two signatures, this. So nurses were complaining to me because I was their consultant. And so I asked this person, the administrator, I will not use his name, let us call Mr. John. Mm-hmm. Hey, John, how come you are so strict? I work with so many ASCs, but you seem to be beyond and above. You're doing beyond and above. Very strict controls. He said, Ram, you would do the same thing if you have seen what I have seen.
Yeah.
I said, would you mind telling me? So he says, yes, don't use my name, don't use the name of my surgery center. Mm-hmm. This did not happen here. It happened at my previous job.
Yeah.
I said, okay, John, what happened? He says, it was Christmas Eve, 24th of Christmas. During December, it gets dark very early, like 5 o'clock, it's dark outside. I was in the office trying to get ready for the holiday. And that year, the Christmas was on a Friday, so we had a long weekend. And I just had to complete certain things before I leave. My medical director comes, puts his head inside and says, hey, have a nice Christmas and this and that. He says, I'm leaving, and he goes. 15 minutes later, John goes out to the parking lot. He sees one car other than his car. Everybody is gone. He identifies the car right away. It is the medical director's car. He wonders 15 minutes before he left, what is he doing here?
Yeah. On Christmas Eve.
Christmas Eve.
Yeah.
So he goes and uses his flashlight from his phone and looks inside. he sees his medical director passed out with a needle in his arm.
Yeah.
So the first thing he does is runs back into the surgery center, gets Narcan,
Yeah.
comes back, he cannot open the window. So runs back, gets a chair,
Yeah.
and with the chair, he hits the window glass, opens it, and then administers Narcan to the medical director.
Yeah.
And then he calls 911 and they come, and then he survived.
Yeah.
Maybe because he got the Narcan, but everybody is not that
Not lucky, right.
And then John tells me, this was the person I worked for 5 years.
Yeah.
I could not believe he's such a nice person. He's an anesthesiologist. He was very nice to everybody.
Yeah.
I could not believe. So now I don't trust anybody.
Yeah. That's a good story. That's a good lesson for all of us. I think, we can get complacent in our center because we're very team oriented as people in surgery centers,
right.
and I think it's easy to trust those individuals. But as you said, it could be the people that you've known for so long. So what can we do? What can surgery centers do? And you work with a lot of surgery centers. I think
Yes.
I can't remember how many you mentioned, but quite a number of them.
Yes.
What are some of those things that are most important to put into place to assure that you're not going to have a problem?
Division of duties. The same person should not be in charge of ordering and receiving.
Yeah.
Always have two people when you receive the drugs or when you count the drugs in the morning and evening. Two people, two different individuals. And when you issue the drugs to anesthesia staff, make them sign your log.
Mm-hmm.
Same thing when they return the unused drugs, make them sign the log along with the RN. Say RN and anesthesia person must sign when it is issued and when it is returned.
And not just pre-sign it either. That's the
No,
other thing I see.
no pre-signing.
No, but we're seeing that. I mean, people trust their colleagues, and you can't do that.
Watch the waste.
Yeah.
Waste is number one area where diverters attack.
Got it.
Okay? And we know we have to have a co-signature for all controlled substances waste. And you don't know what they're wasting, whether they're wasting saline in the syringe or is it fentanyl.
Yeah.
You have no idea. So provide the containers to waste so that it doesn't remain for long. Or don't wait until the end of the day to waste.
Right. Wasted in between procedures.
Yes. As soon as it is done, you waste. Audits can give you some idea if anything is happening in your centers. Get the wholesaler report every month or every quarter and reconcile it with your daily count logs. Everything that came in must be entered in the log. Mm-hmm. Don't depend on individual invoices because they can be torn and thrown away. So you will never know it came in. So
Right.
get the wholesaler reports so they can give you a report on everything that was supplied to you for a specific time frame. And then reconcile also the amount used and amount documented. Be very careful if someone is pulling a larger size vial of fentanyl than needed.
Right.
Usually in the post-op area, you can frequently get orders for fentanyl 25 micrograms every 5 minutes up to a maximum of 100 micrograms. And if the facility has both 100 micrograms and 250 microgram vials, if a RN is pulling from the narcotic cabinet the 250 milligram vial, when there is a choice, the person knows the maximum administration amount is 100, why to pull a 250 microgram vial from the cabinet and waste 150 micrograms? That should be a warning sign.
Right.
So there are several warning signs. If you look closely, you may find. And drug diversion by healthcare personnel is more common than most would believe.
Right. I've seen a lot of it. I mean, we have 87 centers that we work with, and in any given year, we're going to have at least one situation among those centers. And again, it's always those people that you kind of least expect.
Right.
There's so many other people we can name, and my feeling too is that, as I mentioned earlier, we tend to get very lax about the security. We leave the anesthesia carts open when we leave the room. There might not be anybody in the room for a while, and then there's people going in and out of those rooms constantly. Those are easy
Like
solutions.
I said in my presentation, the worst case I have seen is fully drawn up syringes.
Yeah.
In 2 cups, red cup and green cup, not even labeled. When I question them, they say the red cup syringes are fentanyl, green cup is Versed, and propofol is the white milky liquid.
Yeah.
So they drop these drugs in anticipation of using them, but they are attacked by the diverters.
Right.
Because you may never know how many syringes are actually there at any given time.
Yeah.
And don't drop syringes in anticipation of use.
Right. Well, and as a surveyor, I should point out that runs against the regulatory requirements and accreditation requirements also. You have to be very careful.
Yes.
And only draw up what you need for the patient that you currently have.
Yes.
You can't draw it up for other
Yes.
patients.
And also, like I said, Pyxis and Pyxis-like machines give a false sense of security and false sense of confidence that nothing can happen. But like I said in my presentation, the diverters are very clever.
Mm-hmm.
Their only goal is where their next dose is coming from.
Right.
And, they can bypass the safety mechanisms, built-up mechanisms in the Pyxis or Pyxis-like machines.
Right. And I like the point that you made about keeping an eye out for or looking for signs that somebody might be using or diverting drugs. That should be part of every surgery center's impaired staff member policy, so that you encourage people to report or to. It sounds like tattling, but you're really helping to save their life, really.
Yes, I think anonymous reporting by staff members can be useful, but you have to be careful how you evaluate.
Yeah.
Personal animosities can play a role in
Don't
this.
jump to conclusions.
Don't jump to conclusion because you received an anonymous tip. Don't make a decision based on an anonymous tip.
Right.
Confirm, verify before you do anything, because these things can happen.
Yeah.
I know a case where a RN was fired because she was not getting along with the other staff members, and she reported to the DEA.
Yeah.
She reported to everybody, DEA, Joint Commission, IDPH, that some hanky-panky going on here.
Yeah.
And when all 3 of them showed up next week, the administrators were surprised. But then this nurse was telling her friends who still work there, see, they do this to me, I take care of them.
Oh, yeah.
So
It's like a vendetta.
Vendetta, yes.
Yeah. One other thing that was brought up during the session, I think propofol is one of those drugs that, I think a lot of us are still surprised that it's not a scheduled drug. And you talked a little bit about it. I think the person that asked the question asked, is that ever going to be a scheduled drug?
We don't know. It is state-scheduled drug in some states.
And that's, by the way, thank you for mentioning that. That is something that I was unaware of. And for our listeners out there, do double check in your state to make sure you know what the state regs are.
Yes. Similarly, like ephedrine is a controlled substance in Illinois, but not in Indiana. So I work in both states. So in Indiana, it doesn't have to be counted. It is treated like, I have not seen anyone diverting ephedrine injection. It is so expensive.
Yeah.
It became a law in Illinois during the methamphetamine epidemic.
Yeah.
Pseudoephedrine and ephedrine, where people were buying in large quantities and converting them into meth.
Yeah.
So to prevent that, this law came. But unfortunately, they made ephedrine injection also controlled substance.
Yeah.
Which had its unintended consequences of requiring additional burden on the ASCs.
Yeah. I just want to end by one of my pet peeves is making sure that surgery centers hire pharmacy consultants, even if their state doesn't require it. Many states do require it, of course, but as we can end, since you are one, talk a little bit about the benefits. What can you bring to a surgery center? What makes hiring a pharmacy consultant so helpful to a surgery center?
Okay, number one, I assist the centers with the compliance with the accreditation agency standards,
right?
Medication management standards. Number two, with CDC's guidelines.
Right.
3, state public health department guidelines.
Right.
4, DEA regulations, most important.
Right.
Many are sometimes unaware of the DEA regulations and guidelines, and when I tell them you can't do this or you need to do this, they would be surprised because they are unaware of those things. So I will pull the DEA regulation 21 CFR 1304 or whatever, and give them a copy of that and explain it to them. See, this is the regulation you need to follow in terms of documentation, in terms of ordering, in terms of case, in terms of disposal, all those things. So every 3 months I will visit my clients, and I do run audits, like I said, purchase audits for compliance, and I provide a written report after every visit, and if there are any shortcomings, I let them know before I leave verbally and also in writing.
Got it. Yeah, and thank you very much for that. I do think it's so important to, even if you don't, I really encourage every surgery center, no matter whether the state requires it or not, to have a consultant. If for no other reason, to have somebody to call when something goes wrong. And that's one point I really want to end with, is that whenever you have a pharmacy issue, make sure that you contact your pharmacy consultant first.
Yeah, most of my centers do.
Yep.
I am the first one to know if there is a diversion.
Right, you better be.
Suspected diversion.
Yeah.
And some also call me if there is a medication error.
Yeah.
Rarely it happens. Some also call me if there is an adverse drug reaction. They will send me the report, incident report, and they want me to comment on that. Or when I go there next time to review that chart, to see how we can prevent it. And those are the things. And I tell my clients, don't call me by phone if possible. Text message or email is preferred. And I will respond to you within 24 hours. And if it is urgent, if I get a text message, I will, within a couple of hours, response is quicker.
Right. Ram, thanks so much for your time. I really appreciate it.
Sure.
Great presentation.
Thank you.
Nice
meeting with you.
Same here.
Bye-bye.
Next, I had an opportunity to meet with my friend, Ruben Garcia. He's a life safety surveyor with HHC, and he is also a life safety consultant. And he spoke in the conference about common life safety citations. So let's listen to that interview. I'm here with Ruben Garcia. Ruben, you've been on the podcast at least once before, I think during ASCA 2024.
That's right.
We're here at the 2024 Illinois State Association meeting in Chicago, and you just finished a session on the Life Safety Code. Great job, by the way. So thank you so much for imparting your knowledge. Now, you're a surveyor, like I am, with HHC. You're a life safety surveyor. I'm a health surveyor.
Right.
Tell us a little bit about your background and what you do.
Yeah, so I... full-time, I'm a market director for facility management back in Houston for Common Spirit Health. So I manage about 5 hospitals there in the greater Houston area. And I also do consulting, independent consulting for ASCs and hospitals in regards to life safety. And then, of course, I'm also a life safety surveyor for AAAHC. Right. So that's my background there. And then I also got a device called the Airflow Checker and the Gap Checker that a friend of mine we're trying to push out and get out there, and so that's where I'm at.
You got a lot going on, and as a matter of fact, you work a little bit with our company too. We refer some of our business to you when we have a need, and I appreciate that. Yeah. So, Ruben, one of the things I think sometimes, especially new administrators or people that have never been through a survey before, are not always aware of is what is going to happen when that life safety surveyor shows up. Remember, they're only there every 3 years, so depending upon where you are in your cycle in life or cycle in your career, you might not know exactly what's going to happen. What can an administrator, whoever is going to be walking around with the life safety surveyor, expect when he walks in the door?
Yeah, well, what you're going to expect is basically a tour of the building to ensure compliance with the life safety code. That's the gist of the whole life safety portion. Is the life safety code comes from just that. It's an NFPA standard called the life safety code, hence the term we use a lot, right? Because when I think of life safety, when I first got into it, I think of life safety in the context of like saving lives, like actual lives, right? More on the clinical side. But however, the life safety code is in the context of fire safety.
Right.
And that's what we're looking for. So the surveyor is going to be looking at the physical environment, the totality of the physical environment, and then they're going to review documentations that pertain to maintaining that physical environment for patient safety.
Right, and we do have to remind our audience that the Life Safety Code is a copyright of the National Fire Protection Association, the NFPA, and that comes out of NFPA 99 and 101.
That's correct.
So one big part of the conversation that you had with our audience today was what are some of the common things that you find that you end up having to cite during a life safety survey?
Sure. So some of the common deficiencies that I'm finding is issues with airflow, air pressure, and humidity. And so, it's the operating rooms that everybody maintains, and we all know they have to be positive pressure. It's what I would say those less critical areas, such as your soil utility rooms, your clean supply, patient restrooms, those other rooms that are required to have a pressure differential that often seem to be going neglected. And so I've seen a lot of issues around that. As it pertains to humidity, I'm seeing a lot of the devices that they're using are not certified or calibrated devices. Mm-hmm. Other issues that I'm seeing is the dreaded unsealed penetrations.
Yeah.
I mean, it's like, everywhere we go, we see unsealed penetrations. That's another common deficiency. And I would say some lack of testing and inspection on the documentation side.
Yeah.
Those are probably my top three that I would say that I see when I'm surveying.
So from a documentation standpoint, what are the types of documents that the life safety surveyors are going to be looking at when they come into your surgery center?
So we're going to be looking at a lot of inspection and testing documentation as it pertains to your generator maintenance, your fire alarm maintenance, your sprinkler maintenance, your fire doors, eye wash stations. I mean, you name it. Anything that has to do with the physical environment, there's going to be some type of requirement to test and inspect.
But Ruben, I'm in a building. I'm in a medical office building, and the landlord takes care of the fire alarm and takes care of the sprinkler. I don't have to worry about that, right?
Oh man, that's an interesting point you say, because that's an interesting dynamic that a lot of ASCs run into. Is they have to deal with the landlord, who is the one in charge of doing a lot of this testing, right? And some of this testing that they do is compliant, but it's partially compliant because it doesn't check all the boxes. There's certain testing that has to occur. Like, for example, you do the annual fire alarm test, but there's a semi-annual battery load test. Right. That seems to be a low-hanging fruit for a lot of ASCs, is because the landlord doesn't have that in their contract, right? Mm-hmm. So it comes to that. It's understanding what those requirements are. So that's some of the issues that we see there.
And, of course, whatever your landlord doesn't do, you're going to have to do. I mean, I guess a good example of this, let's say that I'm a tenant in a building, and I'm on the second floor and halfway down the corridor there, and the landlord doesn't do any testing of the emergency lights throughout the building. What is my responsibility going to be?
Well, your responsibility would be for your ASC at a minimum, and then the path to get out of the building. Yeah. So as you go down the stairwells and you go out to the public way, you're still liable to make sure that if your patients or your staff had to exit that pathway, that everything's going to be compliant. Which,
of course, means that you might end up, the surgery center might end up having to test the emergency lights in the building's stairways or in the ground floor, getting out to the exit.
That is correct, because it's technically outside of the ASC, but it's still within that path of egress, the means of egress. So that's a great point.
Now, not every surgery center is on multiple floors, but there are special rules, of course, special requirements with regard to elevators. What are you going to be looking for with regard to elevators?
When it comes to elevators, one of the documentations we're going to be looking for is a monthly testing of the firefighters' operations, or also known as the recall testing. And so that's one of the main components we'll be looking for. Also, making sure that you're following your local AHJ guidelines as it pertains to annual testing of the elevators. Mm-hmm. And then there's also a 5-year load testing, where they, have you ever seen the elevators where they say maximum capacity 2,000 pounds? Mm-hmm. Well, they have to test that every 5 years. They'll put some counterweights in there and actually ensure that it can meet that capacity.
It's kind of scary to me. Hopefully the elevator does make it. Otherwise, we have an interesting situation.
Or we change the capacity, right?
Yeah, right. I don't think I'd want to find out.
Right.
A big issue lately in a lot of surveys has been the issue of emergency electrical systems. And I know HHC has really been on top of this, really been keeping a very close eye on this at surgery centers. Can you talk about a little bit about what we're finding, especially with regard to organizations that might be doing deep sedation or general anesthesia?
Oh, definitely. Yeah, that's a major one for new ASCs. And so if you're doing the deep sedation, and then you have to have what's called a type 1 electrical essential system. And basically what that means is you've got to have emergency power split into three distinct branches. Mm-hmm. One of them is the life safety branch, one of them is the critical branch, and one of them the equipment branch. So critical, equipment, and life safety. And really the gist of it is there's only certain authorized circuits that can be on those branches. Mm-hmm. So for example, the life safety branch can only have exit signs, egress lighting, anything associated with the generator, the fire alarm, power source, things of that nature. I can't just put a receptacle in Nurse Nancy's office, right? Or even other receptacles, because it's specific to life safety circuits. Conversely, for your critical branch, you're going to have all your red outlets, anything in task lighting, things associated with that, any refrigerators that are critical for medications and things of that nature. And then the equipment branch, I would say, is more of like an auxiliary circuit or branch. You can put other components that may not necessarily be on there, like, for example, your air handlers, things to keep the operations going if you did have a power outage.
It's almost like a miscellaneous
Correct,
thing.
Yeah,
definitely. Like you decide you want to have all of your computers in a particular area on, for electricity. There's no requirement that you would have that, but certainly if you want to add that, that would be the branch you would put those on.
Exactly.
What do you find, though, when you go into a center, maybe an older center that doesn't have a type 1 system, and yet they've told you that they're doing deep sedation or general anesthesia?
Yeah, that is a big issue, because you essentially change your operations, and means you would have to change your infrastructure of your electrical equipment, and that could be very costly. So that's a great point you bring up. So if they've changed it, they've essentially changed the type of status they should have, category of electrical essential equipment they should have. So that could be a major finding, because now they're, to your point, they've essentially went from a type 2, which is less stringent, to a type 1 that has more requirements.
Well, but to that point, you might have been you might have been doing those types of procedures. You might have been required to have a type 1 system, but you, Ruben, walk in and you tell them for the first time that they have to have that type of system, and they say, well, Ruben, we've had these surveys for the last 20 years and nobody's told me this before. Oh
yeah, we get that all the time, and really a lot of it I can say is every surveyor is different. And not everything's checked, to be honest. I mean, everyone has a checklist, but those things happen often because, it's just the nature of the beast, really.
Yeah, no, and that's important. I think one of the challenges that I have as a health surveyor, as we were kind of alluding to, is that I'll walk in and find something that they've been doing for years and years, and I'm the first one that discovered it. It actually just happened this week while I was doing a survey in Maryland, and nobody had ever brought it to their attention before, and I pointed out it's probably because I looked in a cabinet that probably nobody else looked in before. But to that point, we're surveyors, we're human. We have a lot to look at while we're out on site. We try to do the best job we can, but we might not be looking at every single area. I mean, you run into that a lot, right?
Yeah, I mean, at the end of the day, it's a sample survey, right?
Yeah,
I mean,
that's a good point.
If I go and do the same survey as someone last week, we're going to traverse different areas of the building. Yeah. When it comes to looking above ceiling, I might pop this ceiling tile and look at this, particular wall. He may look at another particular wall. So it's all subjective when it comes to that.
Yeah, surveys would be a lot more expensive if we, and a lot longer if we had to look at absolutely everything that needed to be done. So that's important. And I think you as our listeners out there just have to remember to not become complacent. As a matter of fact, I would actually go so far as to say if I had a perfect survey the last time, I'd be a little bit afraid this time.
Right.
Because as surveyors, right, when we see that, we're looking,
you're like,
for more.
Okay, no deficiencies. Let me see what I can find.
Right. Well, and what happened? Was it a surveyor that might not have been as experienced the last time around? Because it's just so rare. I'm sure you're like me. I've never walked out of a survey. Sorry, listeners, that might be getting me as a surveyor soon. I've never walked out of a survey with no deficiencies, with zero findings.
Yeah, no, definitely.
So, well, I appreciate your time, Ruben. Thank you very much. We'll put your contact information into the show notes here, and as always, it's great talking to you.
I appreciate it, John. Thank you, sir.
Thanks. And next, our dear friend, Katie Pearson. She is the Director of ASC Solutions with Surgical Information Systems. And she spoke, Sue, about policy and procedure changes after implementing an EHR. And it was funny because when we did the interview, the two of us can talk on and on forever. But for some reason, we ran out of things to talk about. So you'll see how we kind of diverged a little bit off the main topic. So I was worried that when her session came that she might not fill the whole time. But guess what? That wasn't the problem. She actually went over. So let's listen to that interview next. I'm here at the Illinois State Association meeting. It's August of 2024. I'm here with our dear friend and quite a frequent visitor here on the podcast, Katie Pearson with SIS.
Hi, John.
Welcome. How you doing? It's great to see you again. I asked you a while ago if you've actually gotten taller, because it seems like every time I meet you, it's just the shoes that you're wearing.
Probably.
Or maybe
maybe you're getting shorter.
Well, it's great to see you here, and you're doing a great presentation. You haven't done it yet, actually, on the policies and procedures with EMRs. I just want to relate a story. I remember a while ago, one of our clients was in the middle of a survey, and I was called in to be with the surveyor. And the surveyor came back and said, I looked at the medical records, everything looks good, but when I looked at the policy manual, your policies are all for paper records. And I said, well, it's because they have paper records. And the surveyor said to me, no, John, they're all electronic medical records.
That's right.
And I said, no, they're paper. We went back and forth for about 2 hours on that. And then finally, I said, what are you talking about? And what we had found out is they had literally just converted to an EMR system the week before the survey.
Right.
And they never bothered to tell us who write their policies and procedures. And of course, we had to scramble to correct the policies and procedures. But it was an interesting situation because, you're so busy while you're putting together an EMR system, implementing it, that sometimes you forget about the importance of changing those policies.
Right.
And we just had an episode recently where we talked about how important it is for that policy manual to be, number one, a working document.
That's right.
That you're constantly modifying to be in compliance with your actual actions. And then something that's useful to your employees. We mentioned how it's not a good idea to just copy the regs or the accreditation standards. So that brings us really to this conversation that we're having with you in this session that you're having. What are the types of things that you have to consider when you are moving to an EMR from a policy standpoint?
Absolutely. And it's funny because when I was asked to present this, the title was Policies and Procedures After Implementing.
Yeah.
And really it should be what to consider prior to implementing.
Right.
But to your point, a lot of people really, it's an afterthought, the policies. And that's for a lot of things is, that's right, we need to update our policy manual after we've done this. But first and foremost, and you just spoke about this on your most recent podcast, is the HIPAA regulations that surround electronic PHI. So as we all hopefully know, HIPAA is broken down into several rules, privacy being one of them, and then security being another one. And the security rule is really just everything encompassing around those electronic protected health information components.
PHI.
And so if you're not taking the safeguards and the steps to make sure that you're protecting that electronic information now, you're going to get in trouble with HIPAA, or the OCR really.
Right.
So that's something that you have to make sure is embedded within your policies now, is what are you doing? What steps are you taking to protect that electronic information? No more can people, literally lock a folder away for your record. People are accessing it not only out in the open in front of other individuals, but they're able to access it from home now as well. Those cloud-based servers can be accessed from anywhere, which is a great selling point when you're trying to get people to buy it. But when you're talking about safeguarding health information for your patients, it's something that now has to be written down in your policies. What are the steps that we're taking? What are we educating our staff on? What kind of drills are we doing? What kind of tests are we even doing on our staff? Not to get into emails necessarily, but that is something else that people use to communicate information about patients. So, are people doing phishing tests to make sure that you're, looking for that, to make sure people are clicking on the right things and not clicking on things that they shouldn't be. So, so HIPAA is absolutely a big one, a big component of that. Your breach policy
yeah.
now really needs to be more robust than ever, because who are the people that are getting breach incidents are those with the electronic health records. So you have to know all the steps that you're going to take. What are you going to do to mitigate those risks on the forefront? Doing your security risk assessment now is something that's super important that people may, again, not have considered or thought about in the past. And then it's user management.
Yeah.
How are you making sure that the right people have the right access to the system? Your vendors, are you looking at your BAAs and making sure that there's the right terminology in there to support that? And then really big piece too is your downtime procedure. For people who are on paper right now, they don't necessarily have to do a downtime drill, but once you do go to paper or to the electronic record, and you haven't done paper now in years, if something were to occur, does your staff know the steps to take to do that downtime documentation? So
well, and the longer that you're on an EMR system, the more you forget.
That's right.
That what happens when you go back to paper.
That's right.
You don't even have it available. We had a story recently. Like one of our employees went in for a very, very minor procedure and couldn't have it done because the EMR system was down.
Right.
And of course she says, well, wait a minute, you should have an emergency backup procedure for this. Of course, that didn't go very well. Yeah. But yeah, I mean, it's going to happen. It will happen. It's not a matter of if it will be when.
That's right. That's right. And then you have to decide too, if and when that does occur, that emergency occurs, is this a just paper occasion, or is it because your power went out and now you should cancel cases? So then there's decisions that people have to make. Yeah. That's right. Do we go to paper? Do we stop doing cases? Do we shut down? There's all those levels to take into.
You mentioned something I think is important too. As part of your policies and procedures, you should be, well, of course, you mentioned a couple things. Sorry, yeah. Risk assessment. I don't think really many places are doing IT risk assessments or at any level, and there's so much that has to go into that. What is the security you have into your wireless system, because everybody has it. What into your network? Are you using cloud-based? Do you have servers?
That's right.
And the more that you have in-house, the more of a risk that you have that somebody can access that system. So tell us a little bit about, or just kind of remind our audience about that risk assessment and how frequently it should be done.
Of course. Well, HIPAA does ask that you do one. Right. And, they say definitely if you're going to make any big changes to your procedures to make sure you're reevaluating, let's say you're going from from a server-based to a cloud-based system, that's something you're going to want to look at. If you're going to change over your security officer, whom you should have designated within your facility, because that's the person that should be
appointed on an annual basis as part of your governing body.
Right. Yeah. They recommend best practice being on an annual basis, just doing a review, making sure that nothing big has changed for you. But it is making sure you have those certain policies in place that we kind of already talked about before, that you have that security officer in place, and that security officer knows their roles and responsibilities within your facility.
And has training.
And has the training that's recommended as well. And then making sure that your staff has been trained appropriately on all of the different aspects of your system also.
Right. And just like we have checks of our HVAC system, we should be having checks of our IT system.
That's right.
Testing your employees regularly to make sure that they're not clicking on things they shouldn't be.
That's right, yeah.
Clicking on passwords.
Making sure that everyone has their own password and that they have a certain length and that it's all individual. I did walk into a facility where everyone logged into every computer with the same credentials. And my HIPAA flag went off. I said, oh no.
Or nurses logging in on behalf of the doctor with the doctor's password cannot be done.
And what I find fascinating is that a lot of people don't know. They don't know what they don't know. And you go to nursing school or whatever to learn about clinical care. You're not necessarily learning about how to safeguard electronic health information. So it's one of those areas that you are responsible for at the end of the day as a leader within your ASC, but it's not something that is naturally taught.
And there's risk to your license. You're a nurse, you have a license to protect, and the data that you're entering into there, and it's possible access by other people. You give your password to somebody else, and you've given your identity to them also. Those are things you have to keep an eye out for.
Yeah, that's right.
So what do you think is one of the first steps you should take when so let's say you're about to implement an EMR system. What are some of what are some good resources for developing some policies and procedures?
Well, other than your company.
Right.
And ASCA has some really good resources, but really there are companies out there. There's one, it has HIPAA in the name, that will give you some really good policies to work from. Those med trainers, folks like that, also will give you not only some policies to work from, but then those plans as well, those risk assessments. But healthit.gov is a great place to start, so you know what's required of you around specifically those HIPAA components we were talking about before. I always find too, reaching out to my best friends who have EMRs or EHRs.
That's right.
Are those that are going to have those available to me, and I can ask them, what did you guys do when you went live?
That's why we encourage people to get to know everybody during conferences. Right. Here we are at the Illinois Association. You see a lot of ongoing conversations going on. Another point I want to make too is your vendor too.
Oh, absolutely.
Should absolutely be able to help you, and at the very least should be part of that policy. Not so much writing, but the review process to make sure that the system complies with whatever they've written up.
Right, what they're telling you, that how they're going to manage it, and how your data is being managed at the end of the day too. Right. You should have something documented to say, here's how we safeguard your data, so you can show that to anybody who asks, like the OCR. So
So, Katie, that brings up a fascinating topic right now, is that, there really is no major push to move to EMR systems. And I don't see that in the horizon anytime soon, like happened in the hospitals, like happened in physician practices. So rest assured, as our audience. But there's going to be a push because of the need for electronic information. Right. As our quality reporting gets ramped up, and we just listened to Kara Newberry talking about the changes coming down the pike. And please listen to one of our previous episodes where we talk about some of this health equity stuff, which is going to, that's one of those things that's going to require a lot of information from that system. But as we start ramping up and thinking about EMRs, what do you think is one of the, when is the right time to pull that trigger? I mean, have you thought about that, internally?
Well, yeah, I think a lot of it is driven by your change agents. When folks come from facilities that had an electronic system, and then they walk into your completely paper ASC and say, wait a minute, what year is it?
That's right.
That's a time when...
Why can't I read my EMRs? Because they've been copied over 17 times.
That's right. So I think when you have big encouragers like that within your facility is a time to do it, because you have the people that are not only willing, but sometimes also able to do the work as well. Oh, I helped build it in my hospital system, or I helped do it here. I think when your owners are asking for data, specifically surrounding cost management, how much did we spend last month? Well, we don't really know, because we don't have a good system, or it's such a manual process to capture that information. Right. I think when people really start looking at the data, asking about efficiencies within their facility or return on investment on certain things, that's when folks start looking at it more and saying, you know what, as much as I'm against it or I don't want to do it, I think it might be good for us so we can get that really good quality data out. And
I think we're also going to see our payers demanding more of this in the future. Yeah. It's interesting you bring this up, because I've also worked with attorneys. I remember a speech many years ago where I think it was Sue, actually, our co-host here, who asked the question, which do you prefer, an EMR system or a paper system? And there were two speakers or two attorneys, and both of them said paper any day. And their comment was, that so often people implement an EMR and they go through the defaults. So, they have a drop-down box that automatically selects one particular option. And those are killers of EMR systems in a lawsuit for that. So you got to be prepared for the ramifications of that. So you got to be ready for that transition.
That's a huge, huge call out, John. I can't agree with that more, that don't just go with the in the box, or out of the box, template that is available to you. Really look at every component and what it is that everyone's going to be required to document at the end of the day. Just because it's there doesn't mean you need to click it, or you need to make sure you do click it if it is there. So I can't agree with that more in that aspect. And another component that I talk about at the end of my session today is surrounding that a little bit in now that you've implemented this system. What are you still doing that maybe you shouldn't be doing anymore?
That's a good point. Yeah.
Folks typically, we've been doing it this way forever and ever and ever. Just because we have a computer doesn't mean it's going to change. It might need to change, though.
Yeah.
Stop printing out 1,000 copies of the schedule every day if now you have your schedule blasted on a TV up on the wall.
Yeah.
Things like that where... stop with the sticky notes if your system now gives you a sticky note capability.
Right.
I see a lot of times when people go live with the electronic system, they get frustrated because it's taking them longer.
Yeah.
But it's taking them longer because now they're doing what they used to do, and now they're also doing the new way. So it's also looking at your full process, your day in the life of a patient, and asking yourself, am I taking full advantage of this system?
Right.
Are we using it to its fullest capacity? And then where can we maybe shed some time off from the ways that we just used to always do things?
Well, and that probably brings up the last point we should say is that this is not a process like that client that I started the conversation with. It's not a process that you suddenly implement like 1 week and then think that everything's going to be done.
That's right.
You got to spend months, if not a half a year or more, looking at systems, making sure you talk to the vendors, talk to people that use the systems, talk to people that use the systems. I mean, love your employer; they're good friends, but we all know that we want to talk to the people that actually use it.
Of course.
And then don't implement it without a lot of training before it even goes live.
And then after the fact, allow for that reevaluation at certain points, 3 months, 6 months, a year down the line, to that point of things are going to change. You might need to make tweaks. Allow for that and make those tweaks. Don't just keep going along because you liked how it was built on day one. So
and be ready. And that's a good point. Also, with getting back to policies and procedures, how important it is that those things never collect dust. That you're constantly making changes as you're learning more and more things. Memorialize it so that your employees know how to deal with it.
That's right. Yeah.
Katie, it's always a pleasure talking to you. You always very upbeat, even on topics that aren't necessarily the most exciting topic.
I appreciate
this
it.
is a great time. Thank you.
Thank you.
And lastly, I had an opportunity to speak to Jeannie Dunaway. She's an RN and CASC, and she is with the Effingham Ambulatory Surgery Center, and she's also the president of the Illinois Ambulatory Surgery Center Association. And she spoke about the benefits of being a member of the Illinois Association and the various things going on in the association. So let's listen to that interview.
I'm here at the August 2024 Illinois State Association meeting with Jeannie Dunaway. She's the president of the State Association. Jeannie, thanks so much for inviting me for the podcast to be here. We've had a couple great interviews. I had so much fun yesterday talking to your audience and all the vendors that were out there. It has been a great conference. So welcome to the podcast.
Well, thank you so much, John. It's a joy to listen to you speak. I've heard you several times at ASCA, and so that was one of the reasons we invited you last year and wanted you to come back again this year.
Oh, I'm so excited. I'm about to do that session. Unlike normally I'm one of the first day, so I got an opportunity to actually listen to people yesterday. So, Jeannie, tell me a little bit about what's going on with the Illinois State Association.
So several years ago, we kind of revamped the whole association. We we went back to ground zero and started over again with the help of ASCA. And what we want to do, because the association had become very vague and very, not helpful to its members. And so what we wanted to do was to bring meat to the table, and things for our administrators and our facilities so that they could go back and use it to run their centers daily, and to provide that kind of support that we hadn't had in the past.
Right. And that could be seen in the conference both last year and this year, especially this year. Obviously you have more resources as your membership grows and you're able to do. Last year was a one-day conference, I think, right?
Actually, it was a day and a half last year. That was the first time we had tried that.
Yeah.
But we didn't have the breakout sessions. So,
gotcha.
But the years before that, we had just had one day.
Yeah.
And people just didn't feel like they got enough.
Right.
And so that's why even though we're spending a little more money because, hotel space and things like that and food, all costs a lot of money, but we wanted to see if we could bring more to our members. And that's what we want to do, is provide that content for them. We want to make it worth their while to spend the money to not only be a member of the association, but also to attend the conference. Because for years we didn't have a conference.
Right. And you're joining us in November for the 2-day virtual multi-state conference. Welcome on board for
Yes,
for that.
I'm excited about that. Just to hear, I love going to ASC every year and getting to get the input from all over the country. But I'm really excited about that it'll be virtual and I don't even have to leave my office.
That's right, exactly. And 16 credit hours if you're CAS certified. So it's a great opportunity. A lot of people do. That's one of the reasons we put it toward the end of the year is that people are always looking for those hours toward the end of the year. Tell us a little bit about the other benefits of membership.
So the benefits of membership is we send out emails constantly, but especially quarterly, we put out a newsletter. But if anything happens in our state, any legislation that comes up, anything that can affect how the ASCs in the state operate, we get that out to the administrators or to the members, and that way everyone is kept informed, because that's the hardest part of being an administrator, is running everything locally on a day-to-day basis, but you have to know it all.
Right.
And so that's what we do, is provide those kind of updates. We do provide different. We provide this meeting now once a year to try to bring in extra education and content, and we do have we work with Wiser, but in order to do advocacy for the state,
right?
So that way we stay in contact with those people that keep their ear to the ground as far as legislation goes,
and know things beforehand and be able to advocate on behalf of the industry. That's so important.
As regular civilians, we don't know what's going on that legislative level. You have to have an in order to know where to look and know where to go. And most administrators on their day-to-day life don't have time to do that.
Right, and that's a point I really want to make here too, as the listeners out there from Illinois. Membership in the state association is absolutely critical. I hesitate to say this because I'm a huge advocate of ASCA, and we work with ASCA an awful lot. But I got to tell you, if you only have money for one thing, you got to join the state association first, because there you're going to be dealing with people that are close to you, that are going through the same things you are. But heavens, do make sure that you're able to join both, because that's such an important part of your
and
your
we
membership.
Also a lot of times when ASCA sends something out, then we will repeat it just for those that maybe aren't members of ASCA. So that way if it's applicable to us, we can make sure that all of our constituents know about it.
Absolutely. Tell us a little bit about your board of directors. I know you have a lot of new board members. And
we do. It's a constant change. We're all getting older, unfortunately. We've had several people retire off of the board. And so we're replacing that with new blood. Administrators do change jobs a lot, and so we've had a few leave the state. And we've got a great board of directors right now, and I have our innovative thinkers and problem solvers. And I think that we're going to be working to get our vendors more involved. Our vendor session was a little down this year. And so we want to get them more involved, because then the more money they spend with us, the better program we can present.
That's right. It really, and that's a very important part. Of course, I'm a vendor in many states. I'm not in Illinois yet. I think I will be next year.
Okay, great.
But they help. They really ultimately pay for these conferences.
They absolutely do.
So if you did attend this conference, make sure that you do check in with all the vendors that supported the state association, and look to them first before you look anywhere else.
Absolutely, because even if you don't think that the vendor can do anything for you, I've had multiple occasions where a vendor that I really had no idea that they what they could provide, and have made a lot of great contacts that way.
Right. And speaking to the vendors out there that might be listening to this, one of the nice things about a state association meeting, and one like this here, is that you have a lot more interaction with the people than you'll go for a bigger conference here.
The big conference, it's hundreds of vendors, and there's no way you can even stop and talk to everyone. But where at the smaller conference, you get to talk to everyone, start forming those relationships, and I feel like that it's a more personal level.
And I did speak to a number of the vendors here. A number of them are my sponsors also, and all of them said that they had great interaction, and they got some good leads, which is all that matters.
Right, and we're also going to be incorporating a committee. I believe we talked about it late last night. That for a couple of the vendors to help us pull in more vendors, and to give them what they need.
Right. We do that actually in like New York, New Jersey, both of them have very busy and active vendor committees,
Right.
which really are beneficial to the organization.
Right, absolutely. And being on as a part of the board of the organization, it's it is a time constraint, but also with if we pull from each other, it's really not that much work.
Right.
It's being a part of the board. It's really, we need people to interact, and it's getting better and better all the time.
Well, and that's one point I want to make is while I'm excited about the multi-state conference in November, you can't skip these meetings.
Right.
It is not an alternative to getting, sitting down. I just had breakfast with the two wonderful people I'd not met yet during the conference here. I had a great conversation about,
Right.
About what's going on in their centers, and that interaction is just as important, if not more important, than every other presentation
Absolutely, because we all feel like some days we're on an island.
you have here.
And when you come to a conference like this, especially a small conference, you get to know people, and you can sit and talk and realize, oh, you've got that problem too.
Right,
well,
right.
So do I. So it makes it so nice because you can interact so much closer. And I feel like that, we're getting better and better as we go. And even though I've been an administrator for 15 years and at my center for over 20, but I still learn something every
day.
time I come to a meeting.
Yeah,
And
that's
I
so
feel
true.
like that is key.
Right.
If you take a to-do list home with you, then it's completely worth the money you've spent to come.
Well, and one point I'll make too, as a surveyor, one of the requirements of the accreditation is that you do external benchmarking. And external benchmarking doesn't mean that you have to do it with like 1,000 facilities. If you're benchmarking yourself against somebody that you met during a conference here, that qualifies for benchmarking.
Yeah.
So, and that's cheap, usually free.
Right. Well, and having people like yourselves that are surveyors. We had our life safety, gentleman who was a surveyor.
Ruben.
A lot of times we have the state. They weren't able to come this year because they're so short-staffed.
Yeah.
But, we have those surveyors here that you can always get input from. I mean, I've asked several people a few questions that I had that I wasn't sure about, and I got great input.
Right. Lastly, Jeannie, tell me how you become a member.
Well, so it's very easy. You just go to our website, and you guys will have that on your content.
We'll put a link. Yep.
Yeah, and that's how you become a member. And also the contact information for the board members is on there, so you can always reach out to one of us.
Absolutely. Thank you so much, Jeannie. I appreciate your time.
Thank you, John.
With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our administrator boot camp and the director of nursing boot camp, and in 2023, the business office manager boot camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC-Central patron program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC-Central at asc-central.com. Or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ASCPodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.